I know we're at the top of the hour. It's 1 o'clock Eastern time, so we're just going to give about 1 more minute. I do see some folks still dialing in. Okay, I have 1:01 p.m. Eastern time, and so we will go ahead and get started. Greetings and good afternoon, everyone. It is Friday, and it is our spring 2022 all-cause admissions and readmissions measure evaluation meeting. So I welcome you to our call today. My name is Leanne White, and I'm the director supporting this project team for this cycle. I'd like to start off by first thanking everyone for your time and participation. I do understand it's a significant amount of time to review the measures and prepare for today's review. I'd also like to extend a thank you to our developers for being on the call today. We recognize that there is a significant time and effort that goes into the testing, the preparation of the materials, and measure submission. So we definitely want to highlight those efforts and thank them for their time as well. Lastly, I want to extend my continued appreciation for your patience and understanding as we continue to meet virtually amid the pandemic. I do understand that there are challenges that accompany virtual meetings, and I do look forward to that time where we can reconvene in person. However, in the meantime, we will do our best to bridge those gaps in our virtual world, and I do appreciate your understanding and thanks for your continued support. Okay, so I'm going to hand it over to our esteemed co-chair, Dr. Amy Lynn. Dr. Chloe Slocum, she had an unexpected commitment that came up today, so unfortunately she will not be joining us. But we do have Dr. Amy Lynn as our co-chair today, and we will do our best to support her. So I'm going to hand it over to Amy.
Thank you, Leanne, and thank you to the committee members of the All-Cause Admissions and Readmissions Committee here for NQF. Thank you for representing the perspectives of patients, hospitals, healthcare networks, nurses, APPs, physicians, and nonprofit organizations. Your perspectives are unique, and we value your input. As Leanne just said, your time is valuable as well, and we appreciate the time it took to review the measures and to the discussant leadership when they review the next two measures. And finally, clarifying questions can help so many, so please don't hesitate to ask questions or raise a comment. So thank you for joining us today. Leanne, back to you.
Well, thank you, Amy. So again, virtual world, so give us just a brief moment. We'll pull up the slides here and we'll get to our housekeeping slide. So Victoria, if you can go to our housekeeping slide, I'll take a brief moment to quickly review those housekeeping reminders. Perfect, thank you so much. So as most of you know, we are using the WebEx platform today to host the meeting. If you're having any technical difficulties, please let us know. You can directly message our team in the chat. We have NQF next to our name in the participants list, so please feel free to reach out to us and let us know if you're having any audio or video issues. We're here to help. You can also contact us for any issues or just to communicate with our project inbox. So our project inbox is readmissions@qualityforum.org. We'll make sure to monitor that as well throughout the meeting. In the spirit of engagement and collaboration, I do encourage us all to use our video. It just helps us see each other's faces and again, bridges some of those virtual gaps that I was talking about. If you're not actively speaking, we do ask that you place yourself on mute. It just helps us minimize some background noise and interruption. You can do this by clicking on the microphone at the bottom of your screen, pressing it once will mute you, and then you can unmute by pressing again. We also encourage you to use the hand raise function. You can do that by finding your name in the participants list, and then a raised hand icon will appear. So to raise your hand, you click on that icon and then take your hand down. You click on that again. We will be monitoring the raised hand feature throughout our call today. We also I do encourage you to use the chat, but also to verbally, speak up during the call. Definitely want this to be an engaging time for us all. Okay. Once we begin our meeting, our Senior Director, Matt Pickering, will go through roll call and review of disclosures of interest. It's important to note that we are a voting body and therefore need to establish a quorum to vote on our meeting today. So our voting quorum is 14. To hold the call, we do require an attendance of 10. If you do need to step away from the call, we ask you send the NQF team a direct message prior to your departure and then when you return, so that we're just aware of the attendance and we can keep track of quorum. Okay, next slide, please. This is where we're going to introduce our hardworking project team here. Again, I'm Leanne White. I'm the director supporting this project team. Pictured here is Isaac Seichi, our manager, Tristan Wind, our analyst, Matilda Epstein, our associate, and our senior directors are Poonam Bal, and we have Matt Pickering also on the line supporting our team today. Our project manager is Victoria Quinones, and then our consultant is Dr. Tarun Amin. So here is our team. All right, next slide, please. Okay, so I'm going to touch on a couple of agenda items today that we have listed here and that we'll be covering today. We'll begin by conducting that roll call and disclosures of interest, which is very important. We need to make sure that we have that completed prior to the call. And this is where we'll take attendance and establish quorum. We did send out a measure-specific disclosure of interest form to each of the standing committee members prior to the call. We do need to receive this form and have that completed and reviewed to review any potential conflicts of interest. If we do not receive this form from you, unfortunately, you will not be able to participate in the discussions or the voting. If you are outstanding in MS-DOI, we do have that ready to send to you via email, and we will send that to you on the call today. So we do ask you please complete that and then send that back to us in a prompt manner. After we complete our disclosures of interest, Isaac will provide an overview of our evaluation and voting process. Tristan will conduct a voting test, and you should have received a poll everywhere link in your email around right before 11. Again, this will be used if we establish a minimum of 14 standing committee members on the call today. If we do not achieve the quorum for voting, then I will definitely discuss our option to conduct voting. So after the voting test, we'll do a brief introduction of our measures and review, and then hand the baton over to our co-chairs to facilitate that discussion. Within that discussion, we will discuss each criterion and vote on each criterion. We also want to notify you that NQF has designated a time frame for developers to respond to questions and provide clarifications. The co-chairs and staff will collect those questions, whether they're verbally during the standing committee discussions or if they're placed in chat, we will collect those. And then prior to the vote, we will go ahead and open up the floor so that the developer can answer any outstanding questions or concerns that the standing committee had. For the measure discussion, following the measure discussion, we'll review our related and competing measures. We'll then host an opportunity for NQF member and public commenting, and then Tristan will wrap us up with our next steps and timelines. Okay, next slide, please. Okay, so here I will hand it over to Matt Pickering, who will conduct our roll call and Matt.
Great. Thank you all very much. Can you hear me okay, Leanne? And she had not.
Yes.
Perfect. Great to see everyone again in this virtual world. Thank you all very much for your time and commitment to our work. It's very important work, and we truly value all of your expertise and input and engagement during these activities. So as Leanne mentioned, I'm here to do introductions and disclosures of interest. So we, again, thank everyone for your time. We'll be combining the introductions with the disclosures of interest today. So as Leanne mentioned, you received 2 disclosure of interest forms. One is our annual form, happens every year, depending on what standing committee you reside on or you participate in NQF at all. You get an annual disclosure of interest. And the second one is pertaining to the measures under review for this current cycle. So just talking about if you have anything to disclose related to the activities for that measure development or endorsement work. In these forms, we ask a number of questions about your professional activities. And today, We'll ask you to verbally disclose any of that information provided on either of those forms that you believe is relevant to this committee's work. We're especially interested in grants, research, or consulting related to the work undergoing this committee. So just a few reminders. You sit on this group as an individual. You do not represent the interests of your employer or anyone who may have nominated you for this committee. We are interested in any disclosures of both paid and unpaid activities that are relevant to the work in front of you. Finally, just because you disclose does not mean you have a conflict of interest. We do verbal disclosures in the spirit of openness and transparency. Now, I'll go around the virtual table. So starting with our committee co-chairs, I'll ask for your name. So just then state your name, what organization you are with, and if you have anything to disclose. If you do not have any disclosures, please just state, I have nothing to disclose, to keep the conversation moving. If you experience trouble unmuting yourself, please raise your hand so that one of our staff can assist you with unmuting. All right, so I'll start from the top, and I know that there's some individuals that are not here today, so just for the record, we'll just go ahead and call their names and see if they're present, even though we know they're not. And I do apologize as I go through the list of names. If I mispronounce your name in any way, I do apologize, so please forgive me. So starting at the top, Chloe Slocum. We know she's not here. Okay, Amy Olin.
Amy Olin, Cleveland Clinic, and I'm a physician hospitalist and enterprise lead for readmission reduction for the enterprise Cleveland Clinic. Thanks.
Thanks, Amy. And do you have anything to disclose today?
No, I have nothing to disclose. Thank you.
Great, thanks. John Bulger. John Bulger. Okay. Edward Davidson.
Yes, Ed Davidson, community faculty, Eastern Virginia Medical School, owner of Insight Therapeutics, a clinical research company representing National Transitions of Care Coalition, and I have nothing to disclose.
Great, thank you very much. Richard James Damdera. Richard James Damdera. Okay. Lisa Freeman. Lisa Freeman. Okay. Kelly Goodson. Kelly Goodson. All right. Dinesh Kalra. Dinesh Kalra. Okay. Michelle Lynn. Michelle Lynn. Okay. Siraj Mahajan. Excuse me.
Hi,
Siraj, are you
everyone.
on?
It's Siraj Mahajan. I'm an internist geriatrician out of here, Chicago land. I am aimed at the Society of Post-Acute Long-Term Care Medicine. No financial disclosures.
Thank you, Raj. Jack Needleman. Jack Needleman. Janice Orlowski. Janice Orlowski. Sonia Peace.
Good afternoon. I'm Sonia Pease. I'm serving as the Chief of Quality, Safety, and Patient Experience for the Cleveland Clinic, Florida region. I am an anesthesiologist, and I have no disclosures.
Thanks, Sonia. Gaither Pennington.
Present. I am the data scientist for Bravado Health. I'm a clinical nurse, and I have nothing to disclose.
Great. Thank you very much, Gaither. Rebecca Perez.
Good afternoon. I'm Rebecca Perez. I'm the Senior Manager of Education for the Case Management Society of America, and I have nothing to disclose.
Great. Thank you very much, Rebecca. And Sheila Roman. Sheila, yes, go ahead.
I'm here. Good afternoon, everybody. I am an independent healthcare consultant and also a part-time associate professor of medicine at Johns Hopkins University, and I have nothing to disclose.
Thank you so much, Sheila. Terry Shoulder.
Hi, good afternoon. My name is Terry Shoulder. I am Chief Quality Officer for Ultimate Solutions Health Network, and I have nothing to disclose.
Thank you so much, Terry. Lolita Thompson.
My name is Lolita Thompson, and I'm a registered nurse. I'm a program coordinator at Tier Memorial Hermann Hospital, and I have nothing to disclose.
Thank you so much. Christy Travis.
Hi, I'm Christy Travis. I'm the CEO of the Memphis Business Group on Health, and I have nothing to disclose.
Thank you, Christy. And finally, Millie West.
Millie West. I'm the System Director of Quality in the Office of Patient Experience at Intermountain Healthcare, and I have nothing to disclose.
Thank you, Millie. And I'm going to circle back. I think Lisa Freeman, I think you're on. Are you able to chime in?
Yeah,
yes, go ahead.
I just unmuted myself, sorry. Yeah, Lisa Freeman, I'm the Executive Director at the Connecticut Center for Patient Safety, a regional or local nonprofit, and I have no conflicts to disclose.
Thank you so much, Lisa. And again, anyone else join late that we did not, that was not recognized? So we called your name, but you weren't here. Anyone not speak up? So that was Chloe, John, Richard, Kelly, Dinesh, Michelle, Jack, and Janice. Any of you on the line? Okay. All right, we'll just keep moving forward. So thank you all very much. I'd like to let you know that if you believe you might have a conflict of interest at any time in the meeting as topics are discussed, please speak up. You may do so in real time during the meeting, or you can send a message via chat to our chairs, or chair today, which is Dr. Amy Olin, or to anyone on the NQF staff. And you can see our names at the very top there have NQF in brackets. So if you're not sure who you should send to, you can send to one of us. If you believe that a fellow committee member may have a conflict of interest or is behaving in a biased manner, you may point this out during the meeting. You can send a message to the chair, or you can send a message to NQF staff. Does anyone have any questions or anything they'd like to discuss based on the disclosures made today? And so far, there weren't any disclosures. Okay, so thank you again. And as a final reminder, NQF is a nonpartisan organization. Out of mutual respect for each other, we kindly encourage that we make an effort to refrain from making comments, innuendos, or humor relating to, for example, race, gender, politics, or topics that otherwise may be considered inappropriate during the meeting. While we encourage discussions that are open, constructive, and collaborative, let's all be mindful of how our language and opinions may be perceived by others. So with that, I will thank you all once again and turn it back to the team. So Leanne, I'll turn it back to you.
Thank you, Matt, and thank you everyone for your participation today. So we're going to have a little, so we did achieve quorum to host the call. We have 12 active participants on our call today. So thank you so much for joining us. And so we're able to go through the two measures under review, but we did not achieve the 14 for voting quorum. So we will change up our process a little bit here. So in our slides and in our agenda, we have a voting test. We'll no longer conduct the voting test since we will not be voting live on the call after each criterion. What we'll do is our team has taken the attendance down, and they are momentarily going to send everyone on the call today an email that has a SurveyMonkey link attached to that email. So that will be the voting platform that we'll be using offline because we were not able to achieve that 14. We welcome you if you would like to vote after each discussion on the criterion through that SurveyMonkey link. You can do so for those who are actively on the call today. Following the meeting, we will also send out that same SurveyMonkey link to those who are not in attendance today, along with an official transcript of the discussions. And then we'll have a due back date within that email correspondence at that time. So you should see that following the measure evaluation meeting today. So again, our team will be sending out an email here shortly with a SurveyMonkey link for the voting criterion for each measure. And so you should receive that. If you do not receive that, please let us know. You can directly message us in the chat, or you can email us at readmissions@qualityforum.org and we'll get that to you. Before we move forward, does anyone have any questions about the voting process? We are changing course a little bit right now. Okay. Hearing none, I'm going to turn it over to our manager, Isaac Seichi, who will go over our evaluation and voting process. Isaac?
Thank you, Leanne. I'll go over the evaluation process that will be followed today. Our standing committee members act as a proxy for the NQF stakeholder membership. They evaluate each measure against each criterion, and with that, indicate the extent to which each criterion is met and the rationale for the rating. They also respond to comments submitted during the public commenting period, make recommendations regarding endorsement to the NQF membership, and oversee the portfolio of measures. To go over some ground rules, we'd like to emphasize that this is a shared space and there is no rank in the room. We encourage you to remain engaged in the discussion without distractions and hope you're prepared and have already reviewed the measures. Please base your evaluation and recommendations on the measure evaluation criteria and guidance. Keep your comments concise and focused, be cognizant of others, and make space for others to contribute to the conversation. Next slide. In terms of how the discussion will proceed, we'll start with an introduction of the measure by the measure developer. The lead discussant will then briefly explain the information provided by the developer on each criterion, followed by a brief summary of the pre-evaluation comments from the committee, which will emphasize areas of concern or differences of opinion. The lead discussants will also note preliminary ratings by NQF staff, which is intended to be used as a guide to facilitate discussion. Developers will be available to respond to questions from the standing committee. Afterwards, the full standing committee will discuss and, under circumstances where we have quorum, vote on the criterion if needed and move on to the next criterion. The following is a list of our endorsement criteria. 5 areas are outlined here, namely importance to measure and report, which includes evidence and performance gap. We have scientific acceptability, which includes reliability and validity. Please note that the first 2 bullet points are a must-pass criteria. We also have feasibility, usability and use, and related or competing measures. The use sub-criterion is a must-pass for maintenance measures. The next point of discussion is the comparison to related or competing measures, which is a discussion and does not require a vote. That discussion only takes place if the measure is recommended for endorsement. Again, these are the criteria the measures are evaluated and voted on. Next slide. During a time where we have quorum and there's a live voting, if a measure fails on one of the must-pass criteria, there is no further discussion or voting on the subsequent criteria for that measure. The committee's discussion will move on to the next measure, if applicable. If consensus is not reached on a criterion, the discussion will continue to the next criterion, but there ultimately will not be a vote on the overall suitability for endorsement. As far as achieving consensus, quorum is 66% of active standing committee members, and that is 14 out of the 20 active committee members for this project. We need greater than 60% yes votes to pass a criterion or recommend a measure for endorsement. Yes votes are the total of high and moderate votes. 40 to 60% of committee members voting yes will be consensus not reached. And less than 40% voting yes means the criterion does not pass or the measure is not recommended, depending on what we're voting on. The consensus not reached criterion and the vote on the overall suitability for endorsement would be postponed should a CNR take place. If a measure is not recommended, it will also move on to the public and NQF member comment. But the committee will not revote on the measure during the post-comment meeting unless the standing committee decides to reconsider based on submitted comments or if the developer submits a reconsideration request. Slide. As mentioned before, please let us know if you need to step out of the meeting. We need 50% of the standing committee members on the call to continue the discussion. And in a moment where we have quorum, should we lose quorum at any point in time, we would be sending an offline survey, which is the scenario for today's meeting. So an email will be sent out shortly containing the survey link for voting to take place offline. Next slide. At this moment, I'd like to pause to see if there are any questions. Here none, I will turn it over to Leanne.
Thank you, Isaac. Okay, next slide, please. Okay, so we will go ahead and start our measures under review. The project team received 2 maintenance measures for the spring 2022 cycle. Next slide, please. The 2 measures we received for review is 2827 Point Right Pro Long Stay Hospitalization Measure and 2375 Point Right Pro 30. The measure steward is American Healthcare Association and the developer is Point Right Inc. Okay, next slide, please. We did not have any, both measures were not reviewed by the scientific methods panel for the spring 2022 cycle, but I'd like to take a moment to describe the scientific methods panel and their role as part of the measure review process. The scientific methods panel is a group of researchers, experts, and methodologists in healthcare quality and quality measurement. The panel reviews complex measures and provides comments and concerns to the developer. The developer has the opportunity to then provide further clarification and update their measure submission before the standing committee evaluation. Again, I reiterate, there was no measures that were reviewed by the SMP. Okay, next slide, please. Okay, with that, we'll begin the review of our first measure. I do want to remind everyone on the call today that the measure evaluation materials are attached to your invite and were sent also in email. We did we sent out the measure evaluation worksheets that include the NQF member and public comments, as well as the standing committee feedback during the pre-evaluation phase. So please let us know if you need us to resend those, but they should be, they will be located in your meeting invite. Our co-chairs, Dr. Amy Lynn, will start by introducing the measure today. The developer will have an opportunity to provide a brief 3 to 5 minute overview of their measure. Our lead discussants will introduce the criterion and highlight their main takeaways. Our supporting discussants will then respond to the lead discussants and add their own insights as well. During the criterion discussion, Dr. Lynn will collect questions for the developer. Once the initial discussion on the criterion is complete, the co-chair will ask the developer to respond to questions and clarify any information. Once the standing committee has completed its discussion, we will move on to the next criterion, and the voting will take place again offline via the SurveyMonkey link. Okay. So our first measure that we will be reviewing today is 2827 Point Right Pro Long Stay Hospitalization Measure. Again, this is a maintenance measure. The measure steward is American Healthcare Association, and the developer is Point Right Inc. The brief description of the measure is on your screen today. The Point Right Pro Long Stay Hospitalization Measure is a minimum data set based risk-adjusted measure of the rate of hospitalizations of long stay patients, also known as residents of skilled nursing facilities, SNFs average across the year, weighted by the number of stays in each quarter. I will now hand it over to our co-chair, Dr. Amy Lynn, to lead us in the discussions of measure 2827. So Amy?
Great, thank you so much. So this is the Point Right Pro long stay hospitalization measure, number 2827. As mentioned, this is looking at the long-term care patients in our skilled nursing facilities, looking at the rate of hospitalization averaged across the year and weighted by the number of stays in each quarter, which accounts for heavy viral seasons or other reasons why people are good in the hospital a lot. Let me first introduce our patient advisors on the call. There's going to be 3 for the committee, but 2 are represented today are the patient advisor groups who are looking at the measures through the lens of the patient and their family. And I'm hoping that Dr. Sonia Pease or Lisa Freeman can help frame the discussion on 2827 with a comment about how the patients or families would be affected by this measure.
Thank you. This is Sonia Pease. You can hear me? Yep.
Yes.
No, I mean, as a patient perspective, you know, I think this is a good measure in a sense that we want to make sure that we're getting the right care in whatever setting we're getting that care. And so ensuring that we're getting the appropriate care when we're in a skilled nursing facility is certainly as valid as making sure we're getting the appropriate care in a hospital. You know, I think this measure, you know, it meets a lot of the goals that we as patients would want, making sure that we're doing the preventative things to prevent complications, so that we don't have stays that extend too long or have things that require us to go back to, you know, back to an acute care setting. So no, I don't think from a patient perspective, this is, you know, this is a very valuable measure.
Thank you so much, Dr. Pease. Any comment from Ms. Freeman?
Yes, I do actually. I think that from patient perspectives, being cared for in a skilled nursing facility, you know, long-term residence, it's a very frightening prospect, and there are a lot of health issues because you're now in a community. So you are subject, as we saw during the COVID, you know, the height of the COVID pandemic, these were the facilities that were hit the hardest. And there's a reason why. So I think that measuring admissions into hospitals points out that not that something went wrong, but maybe that something could have gone better. So if it's available, if this information is available to patients, which I don't see anywhere in the information that it is, but if it should be and can be, then it helps patients to differentiate perhaps one nursing home from another. And it certainly highlights for the people involved in the running of them, where there might be areas that they need to attend to. Why are people going into the hospital from their homes? Because there are certain problems that are directly related to some of certain hospital admissions. So I just want to say, I think this is a very valuable measure. And it also points out the disparity in care between certain populations and things like that we need to focus on and give attention to. So yes, thank you for letting me speak, and I'm glad it's included.
Thank you so much for your comments, both. Let's turn now to Kieran Srinivas, who will present an overview of the measure.
Thank you. And thanks for those perspectives as well. It's always important to keep the patients in mind, I think, because that's the reason we do this work. So my name is Kieran Srinivas. I'm with the American Healthcare Association, also known as AHCA. Two of my colleagues are also on the call, Marcita Domi and David Gifford. For those who don't know, AHCA is a trade association. We represent approximately 10,000 of the 15,000 nursing homes in the nation. Given that we represent 2/3, though, we don't see our work. We see our work we see that our work needs to improve the whole industry, not just our members. And case in point, you know, these measures, the data that we produce every quarter for these, we actually publicly release the raw data on our website. You don't have to be a member to get the data. You don't have to even create an account. And we've done this since the initial endorsement. We have mission as an organization to improve the lives by delivering solutions for quality care, and both of the measures before you reflect us trying to continually live that mission. You know, we pursued this measure because we, you know, saw this as a solution to reduce preventable hospitalizations that can improve lives of residents living in nursing homes. As you know, hospitalizations are risky and potentially traumatic events for frail elderly patients, frequently associated with decline in independent function, delirium, cognitive decline. You know, it puts nursing home residents at risk for new pressure ulcers and hospital-acquired infections. As that old saying goes, you know, if you want to go, you know, go fast, go alone, but if you want to go far, go together, go with others. And this is a great example of that, I believe, of something that we've been really trying to go far with it, you know, from initial endorsement to re-endorsement. You know, I'm thrilled in our application, we were able to report out that we have both of these measures used in the state Medicaid value-based purchasing programs, which help align financial and clinical incentives to improve lives. We also have a great partner in PointRight. It's an analytics company that is in the post-acute care space. PointRight has a relatively new parent company, NetHealth, so I apologize if there's some confusion when reviewing the application and you see NetHealth mentioned alongside PointRight. They're essentially one and the same. NetHealth, we have two people from NetHealth with us today, Nadia and Janine. And I think the other partner is really the NQF, you know, and the steering committee, and providing that, you know, throughout the endorsement process, and we've done the SDS trial and other, you know, things. NQF and its committee has helped us examine our measures and really make it the best it is. So really looking forward to the discussion today. Well, let's talk a little bit specifically about the prolonged stay measure that we're here first to talk about. So we're doing this application with no real changes in our risk adjustment model or measure criteria. Our application mainly contains updated information on trends, validity, testing, and use and usability. And I think that there's an elephant in the room when we put that out there because there's COVID. COVID's happened, you know, in between. And so I want to take a minute to talk about that. So in light of this COVID pandemic, which started in 2020, the decision not to include any COVID risk adjustment wasn't something we took lightly. We look forward to really hearing what the committee has, their thoughts and views on this. Ultimately, we believe it is too early and possibly unhelpful to add COVID diagnosis to the risk adjustment model. For most of 2020, nursing homes had to manage a spectrum of regulatory directives and clinical guidelines to manage COVID case surges and prevent hospital overcrowding. So hospital discharges and admission processes varied unevenly in such a way that we do not believe we can accurately assess the benefits of adding COVID to the risk model. Additionally, most of the underlying conditions that exacerbate the effects of COVID and increase the likelihood of hospitalization, such as COPD, heart failure, diabetes, they're already included in the risk adjustment model. Thus, we're not really sure how much to be gained by including COVID in the model. And then furthermore, with vaccination and antiviral treatments picking up, we're seeing hospitalization rates and deaths decline precipitously. With these rates less than than those associated with influenza, it's not clear to us that adding COVID now or in the future is appropriate. We don't adjust for other respiratory pathogens that increase hospitalizations each winter. So let me close with just a couple thoughts on validity, testing, and use. Regarding validity, we continue to see the measure prolonged stay be associated with 5-star ratings and other measures such as pressure ulcers and urinary tract infections. Regarding use, there is no other NQF endorsed long stay hospitalization measure. We do know that in between that CMS has released a Medicare fee-for-service claims-based measure. They use this on Care Compare and they use this in the 5-star ratings. And while our measure is statistically significant, has a significant association with that measure, we do think it's important that it still remains alongside this other measure. And mainly because that distinction between using what the data source is. Our measure is based on minimum data set assessments, MDS for short. The beauty of using MDS is that it is no extra burden for providers, that they complete this regardless of our measure because of regulatory requirements. And it represents all payers, not just Medicare fee-for-service. And because it's all payer, that's why we believe you see Medicaid UPV programs such as New Mexico's and Colorado's adopting it. We also see managed care organizations have gravitated towards using our measure. So let me end there. Thanks everyone again for taking your time out to be part of this review process. Looking forward to the discussion, and my colleagues and I are happy to answer any questions at any point in time.
Hi, Kieran. This is Terry Shoulder. I do have a clarifying question about the risk adjustment with this metric. Is it based on since it's a long-term resident, is it based on the risk based on their existing MDS, or is it based on the MDS that's done upon admission to the SNF?
It's done on their existing NDS, like the stay.
And I'm hoping that we can, let's also bring that question up again, Terry. I love that you brought that up right off the bat when it comes to validity down the road with our discussion, if that's okay. Thank you so much. Oh my gosh, thank you. So let's begin with our lead discussants then. I do believe Dr. Dom Dara is unable to be here this afternoon.
Amy, can I interrupt for 1 second? This is Lisa Freeman. As a patient, when I go through the paperwork, I have to look up all these acronyms to get through it. Can I request that when we're having our conversations here, that for those of us who are not always speaking in acronym language, that they be identified as what they represent?
Please. That's a great point, because I can hardly keep track of them myself.
Thank you.
So if you hear that.
Sorry about that.
It's okay. Everybody does it. It's just that I get lost.
Good point. So if you hear an acronym, we could raise a flag to say, we don't know. We can also chat it. I bet somebody might know in the chat if the conversation is moving. But great point, Lisa. Thank you for bringing that up. So Dr. Dom Dara is not with us this afternoon. Is there any chance that our other discussants, being Dr. Sonia Peace or Lisa Freeman, can start the discussion on this measure with the, let's see.
Yeah, I'm happy to.
Okay.
So, since this is a maintenance measure, I think, in terms of looking at the evidence of why, of how this measure came to be, I think the evidence strongly supports having this measure. I think there clearly, when you go through the different sections here on the gap in care and the opportunities for improvement, I think these are all very valid points. And I had a couple questions, clarifying questions myself, but I don't know if that's going to be out of order in terms of some of the discussion that we probably want to have around, COVID risk stratification, as well as some of the exemptions.
Right. So, Leanne, should we go through the criteria one, the evidence, and then collate our questions and then ask all the questions at the same time, Leanne?
That's a great question. So we'll proceed with the normal flow. We just won't be voting between each criterion. So if we could, we'll start with evidence first and have the evidence discussion. And so highlight what the developers submitted for the evidence, and then any highlights, takeaways with evidence. And those questions that we gather, will open the floor up to the developer to address those if need be after standing committee discussion. And then we'll move to gap. And so we'll do the same sequence of events and process throughout all the criterion.
Okay, so should we, any questions that come up, like Dr. Peace has some questions, and I know other questions will come up. Should we earmark them for after the evidence is presented?
Yes, exactly. So Terry's question with the validity, so we'll capture that, and then we'll bring that up during our discussion on validity when we review the threats to validity. So we'll gather those questions. So if we can focus on evidence first and present the highlights of the evidence the developer submitted for 2827. If there's any questions that come from the standing committee that the developer needs to address, we'll pause there and allow them to focus on just the evidence criterion, and then we'll move to performance gap. And we'll.
Yeah, and Amy, if I could just add, like what Leanne was saying, so the committee can ask all the questions related to evidence. So Sonia, if you have questions related to evidence, Amy will capture those. And then once all the questions are captured related to evidence, Amy will then go to the developer to answer those questions. And then if there's no other questions from the committee, again, related to evidence, we'll go to, well, we won't be voting today, but you'll move to the next criterion after that.
So the only question I had around evidence was when you got to the logic model. The logic model's a little bit different than the Pro 30 because the logic model now also includes the use of antipsychotics. And I was wondering, is there evidence that around that supports adding that to this logic model?
Okay, so let's put that in our discussion question for after we go through the evidence. Regarding reliability, I believe, is that the first one? Reliability is the first one we talked about? Oh, shoot, no, the evidence. Anything on the evidence we have to talk about right now? Or should we go right to the questions, Leanne?
If the standing committee doesn't have any further highlights or takeaways they would like to discuss among themselves, then we can open the floor up to the developer to address the question related to the logic model. And I just want to preface that the developer, and this is in the preliminary analysis in the measure worksheet, the developer attests that the underlying evidence for the measure has not changed since the last NQF endorsement review. And so we'll, the evidence has been unchanged. And so we can discuss if the committee agrees that the basis for this measure has not changed and that we don't have to have a repeat discussion, but we can ask those questions to the developer. If that helps.
You want me to, this is Kieran, do you want me to chime in about the antipsychotic use?
Absolutely, that would be great, thank you.
Yeah. So there have been studies that show that antipsychotic use over time increases risk of hospitalization. And so that's one of the rationale for including it in the model.
Okay, any other questions on the evidence? If that's the case, do we move on to?
We'll move on to performance gap.
Okay, great, thank you. Does Lisa or Dr. Pease want to comment on the performance gap?
I'll be happy to. This is Lisa. So I think what's been presented to us is that a couple points were made. And one is that the national average of hospitalization rate has increased by 6.5%. And in terms of, and that's, it went from 14.7% and 14.8% to, I lost my place. The bottom line is it increased by 6.5%. When they refer to the disparities, the finding was that facilities that were located in the lower SVI counties had a lower risk-adjusted long-stay hospitalization rate. And the difference in average readmission rates between facilities with low SVI and high SVI counties. And I'm trying to find where I defined SVI. That might be one that I couldn't figure out. So if somebody could tell me what SVI stands for, I'd appreciate that. I mean, I got the gist of it, but I'd like to know.
The CDC's Social Vulnerability Index.
Okay, great. Okay, I sort of took it to be that, but that the difference in the average readmission rate between facilities with low and high SVI decreased over time, which I think is a good thing, but it's still there. There is a difference and the usage is different. So it reflects a need for this kind of a measure so that we can stay, on it and watch it. And I guess that's what I basically took out of that.
Thank you so much, Lisa. Do we have any questions about the gap in care, the opportunities for improvement and disparities? I was wondering.
Oh, go ahead.
Oh, pardon me. I was wondering why, Karen, why would the difference in the average readmission rates between facilities in the low and high SBI counties decrease over time? Is that because of them getting the data from the Point Right Pro so they understand where they are compared to everybody else? I wasn't sure how to explain that.
Yeah, it's a great question, and honestly, I don't have an answer to it. Not really sure what's driving that change for that specific population.
Thank you. Go ahead, Lisa. What were you going to say?
I was going to say that I think that this is what's needed to improve care, because we absolutely can't fix what we don't know. And I think that, you know, a lot of people, we're looking at all the disparities through many different measures across, you know, across the board. So it could be that, to your question, I was thinking about that also. And I think that we are addressing certain issues. We're focusing on certain kinds of infections, healthcare acquired infections, things of that nature. So in some way, we might be bringing the gap, we might be closing the gap a little bit. It would be interesting to see what factors are actually influencing it specifically. But I mean, in my mind as a patient, I'm just glad to see that it's happening.
Excellent point. Yeah, thank you. It is reassuring, despite the lack of figuring out how or why that's happening. But shall we move on to criteria number 2?
So Amy, would you like me to also summarize the performance gap that the team put down in the preliminary analysis to address? We did have a preliminary rating of moderate for gap. So I just wanted to highlight that the developer did highlight that provided re-hospitalization statistics for the skilled nursing facilities nationally for the 2 most recent quarters. So that would be Q4 of 2019 and 2020. So for 2019 and 2020, the risk-adjusted mean rate was 14.7% and 14.8% respectively between those 2 quarters, 2019 and 2020. And so the developer also did provide re-hospitalization rates from the American Healthcare Association member facilities as well. And I know that Lisa did touch upon the rate did increase by 6.5%. I also want to note that in the committee pre-evaluation comments that there were no concerns raised regarding the gap in care and also the opportunities for improvement and disparities. I just wanted to highlight that the pre-evaluation comments from the committee, there were no concerns raised.
Thank you so much, Leanne.
So if we have no further questions for the developer and we can take a brief pause here, then we can move on to our next criterion, which will be the testing portion, the scientific acceptability. And so we'll move on to the reliability section. But we can pause here to see if anyone has any questions that they would like to pose to the developer before moving on. Okay. All right, so hearing none, we'll move on to the reliability section. So I would be happy to review the testing that was done if need be, or I can definitely hand that back over.
I'd much prefer you do it, unless Lisa wants to.
No.
Okay. All right, perfect. So so we're focusing on reliability, which we look at the specifications of reliability. So we're looking at, are they consistent and credible results about the quality of care when implemented? And so for reliability testing, this was done at the patient or encounter level. The developer compared the prevalence of the risk adjustment covariates between a testing sample of 2,584 skilled nursing facilities and the national population using that minimum data set, or otherwise known as the MDS assessment 3.0. The developer continued to note that 45% of the risk adjustment model covariates were found to have prevalence within 5% of the prevalence found in the national sample. They also continued to note that 65%, or 13 of 20 risk adjustment model covariates that were comparable were found to have prevalence within 10% of the prevalence found in the national sample. The developer did acknowledge that although the measure testing sample was not a random sample of all skilled nursing facilities nationally, the Model 4 cohorts are sufficiently represented within that sample. So again, that was at the patient or encounter level. And I'll just pause here to see if anyone has any questions or feedback for the reliability testing at the patient or encounter level.
Is there a time period of when this data sample was taken? Like what was the period of time?
Kieran, for the, would you like to answer that? When was the time frame? I'm sorry, Sonia, you're a bit soft in my ear. When was the time frame for the data that was used for the patient or encounter level testing?
Yeah, it'd be interesting to see if this was within COVID time periods.
It was before COVID. It was part of the initial kind of endorsement back in 2017, I believe.
And I could see on my worksheet, it comes up to be page 42. There's the testing sample facility level descriptive statistics. If I'm not mistaken, that's the 2,584 SNFs using 4 snapshot dates of quarter 3, 2013, quarter 4, 2013, quarter 1, 2014, quarter 2, 2014. Does that sound like, is that the, when they compared the SNFs with point right and not with point right, I feel like that table 1 summarizes the differences and similarities between the facilities for the entire nation in 2014, it says. So it was a while back.
Is there a reason why, I mean, we wouldn't redo those data sampling on a more recent cohort?
So we didn't redo the reliability testing mainly because there was nothing underlying that kind of changed substantially that would change regarding the reliability aspects of it.
It actually, that's an interesting point because I wonder aloud. So I'm not a SNF expert. The point right sample contained facilities of various bed counts, chain versus independent, hospital-based versus non-hospital based, nonprofit versus for-profit. And they were saying that the point right sample had a greater proportion of large for-profit chain facilities than the national SNF population. And even the chains, I mean, I don't know if chains for SNFs have increased over the last 8 years. I wouldn't be surprised if that was the case, and independent SNFs being like snuffed out. Okay, sorry about that. But being a part of a chain in 2014 data for the nation is 56.4%, and for the point right, 83.5. So I just wonder aloud if that happens to be shifting, and I don't know if it would benefit to take a look again, but because point right is still only on a couple thousand, 2,500 SNFs, right, Kieran? Point right?
Correct.
Okay.
There hasn't been much shifting in the demographics in terms of the nation as well as for the point right sample.
Okay.
Amy, would you like me to go through the accountable entity level testing that was conducted for reliability for the group?
Sure
Okay.
thing.
So perfect. So the validity test, or I'm sorry, let me correct myself, the reliability testing at the accountable entity level has not been updated, but there was 2 types of testing at the accountable entity level. So there was reliability of rates over time. The developer analyzed change from quarter to quarter in the observed and adjusted long stay hospitalization rates. The developer explained that their reasoning was that the underlying probability of a skilled nursing facility's long stay patients hospitalizing and the characteristics of its long stay patient population were unlikely to change greatly in a 3-month period. So most of the change from quarter to quarter would be due to limitations on measure reliability. Correlations from one quarter to the next range between 0.884 to 0.894 for the parametric statistic and 0.877 to 0.886 for the rank order statistic. The developer did note that this suggests that the measure is adequately stable over short periods, but sufficiently variable to reflect clinically meaningful changes. And the second type of testing that was conducted at the accountable entity level was the stability of facility level adjusted rate bootstrapping. The developer recalculated adjusted rates for the measure for calendar year 2014 using a random sample of stays. The developer then reviewed the distribution of differences between facilities' original adjusted rates and the rates calculated with a new sample. The developer interpreted a distribution of differences with a small variance and a mean of 0 as acceptable measure stability or reliability. The developer continued to note that 64.8% of the point right sample had a difference in adjusted rates of less than 2%, and only 4.6% of facilities had a difference greater than 5%. The mean difference was 0.1%. I will hand it back over to you, Amy.
Sounds good. So it looks like when the committee had a question about it, as a prelim, no one had any comments about it, but the preliminary rating for reliability came out as moderate. Any other questions about reliability for the developer? Hearing none, we'll move on then to validity testing.
Perfect. And I did want to note in the committee pre-evaluation comments, there were no concerns with the reliability testing conducted for this measure. So for validity testing, this was done at the patient or encounter level, and it was also done at the accountable entity level. So we'll begin with the patient or encounter level testing for validity. This was the agreement of model dependent variables. The developer compared the identification of hospitalizations of Medicare fee-for-service beneficiaries between the minimum data set and Medicare fee-for-service claims. The developer used the 2012 minimum data set data, claims data, and enrollment data because it was the most recent available. The developer did note that there was 241,857 discharges to an acute hospital from long stay discharges. That was an N, a number of 15,091 skilled nursing facilities. The developer noted that 86% of hospitalizations of Medicare fee-for-service patients identified by the minimum data set are confirmed by Medicare fee-for-service claims. The developer further noted that in the other direction, 98% of acute inpatient claims found near a minimum data set discharge have a minimum data set discharge code of acute hospitalization. So overall, the developer explained that the minimum data set discharge assessments appear to be overstating the rate of acute hospitalizations to a moderate degree, and noted that the accuracy of the dependent variables for patients with other payers was not feasible as data for residents is not available. That was at the patient or encounter level. So I'll pause there and hand that over to you, Amy, if the standing committee has any questions or discussions.
Any questions or discussions on that? I was wondering, for the MDS minimum data set discharge assessments, if it's overstating the rate of acute hospitalizations to a moderate degree, is that because observation status patients were in the MDS data set versus Medicare fee-for-service, or was it other procedures like tubes, pegs, catheters that needed attention? Is that why that would be that difference to a moderate degree?
That is one of our beliefs, is that the observation stays was kind of one of the reasons for the difference.
And any chance that that changed over time? I'm just not sure. It seems like that could be a moving data point.
I don't know of anything. I don't know if any. We haven't done any initial, I guess, additional testing on that specifically.
Okay. Thank you.
It's a good question, though, Amy. I mean, because what is when you say a moderate degree? I mean, what is a moderate degree? Is that 5%? Is it
14%? Is that right? There's an 80. There's 40% difference between. Is that right, Kieran? Am I saying 40% between the Medicare fee-for-service patients identified versus the MDS patients identified? I mean, the confirmed claims versus the MDS patients?
Yes, I believe so.
So yeah, it's that fourth point under validity and testing at the patient encounter level. Dr. Peace, it looks like 86% of the hospitalizations of Medicare fee-for-service patients identified by the MDS are then confirmed by claims, 86%. I don't know if that changes.
Yeah, that's a significant variance.
I think one of the, we're talking about this, potentially the estimation, we're capturing more people that are just going in for observation stays. We did think a little bit about, like, from the patient's perspective, an observation stay and a hospitalization, they're quite similar. You're both the disruption of it and everything. So the fact that our measure is capturing people that are just going for observation stay is not such a bad thing necessarily. It actually might be helpful. So that's one of the reasons we thought it was acceptable.
I think that's a great point. It feels the same, just pays different, for the hospital. Okay.
In additionally, I understand that observation, initially it was being overused in a sense, because people didn't know how the people in the hospitals didn't want to have their their reimbursement impacted, so they were trying to follow the ruling as it came out. I think that over time recently they've gotten to understand better what it's intended for, and admissions are actually happening a little bit more, so that the patients don't because patients don't do as well when they go in on observation as when they go in as an admission. And I think that got clarified. So if anything, I think that while it's good that we're counting both, I think we're also miscategorizing some of the admissions less. At least that's what I've been hearing.
Thank you, Lisa. Let's move on then to the validity testing at the accountable entity level.
Absolutely. So there were several testings conducted at the accountable entity level. So I'll start with the first one. So the developer performed construct validity testing by testing the relationship between this measure and the various components of the CMS 5-star ratings for skilled nursing facilities and its correlation with the CMS long stay quality measures. The developer showed that high star ratings were associated with lower adjusted long stay hospitalization rates. The developer also identified the 5 CMS long-stay measures that were significantly correlated with the prolonged stay adjusted hospitalization rate, which were the high-risk residents with pressure ulcers, residents who lost too much weight, residents who self-report moderate to severe pain, residents who need for help with activities of daily living has increased, and residents with urinary tract infections. So those 5 measures were significantly correlated with this measure. Then lastly, the developer calculated the correlation between this measure and the prolonged stay measure. Since the original endorsement, CMS added a Medicare claims-based long stay hospitalization measure to the Care Compare that was mentioned by Kieran earlier, and the 5 stars. The developer calculated the correlation between this measure and prolonged stay. That prolonged stay adjusted hospitalization rates had a statistically significant positive relationship with the Medicare fee-for-service claims long stay hospitalization measure that is used in the 5-star and reported on Care Compare. That correlation coefficient was reported as 0.77 and was statistically significant. I'm a tongue twister. I do want to mention the exclusion. So the developer indicated that there are no exclusions for this measure, which we cover in Validity. However, the measure will not be reported for a skilled nursing facility if the denominator population over the measure's period's 4 snapshots dates is less than 30. The developer continued to note that all patients in the facility on the snapshot date who met the long stay criterion on that date are included in the denominator. And so that wraps up the exclusions, and I'll definitely pause and hand that over to Amy before we go into risk adjustment.
Great, thank you. Any comment or questions about that? The validity testing on the accountable entity level.
Amy, Sonia has her hand raised.
Oh, yeah. Thank you, Sonia.
Yeah, maybe just a clarifying question. So when it says no exclusion, so when patients get readmitted for a planned readmission, if they're having staged or things like that, is that is not counted as a readmission if it's a planned readmission? Is that correct?
That's correct.
I also felt like it was reassuring that the star ratings correlated opposite with the readmission rates. That made sense to me. And I like how it's now noted on Care Compare for everyone to see. That's the patient-facing information. I think Lisa was mentioning earlier that they could use this, the patients can use this information to help guide their choices. Is that also, do we understand that correctly? Kieran, do I understand that correctly?
So our measure is not, this measure is not on Care Compare. It's the other one, the CMS Medicare claims one that is on, that's publicly available.
I see, okay. Lisa, do you have your hand up?
Yes. I'm just curious, why are SNFs that are have an N of less than 30 not included?
It's largely with the reliability of the measure. When you have less than that, you get a lot of swings in like their rates and stuff.
Right. If they're,
oh, sorry, go ahead.
If they were included, though, would that not highlight something about, I don't know, that maybe the smaller facilities offer more attentive care? And I'm just saying that that's not necessarily fact or anything, but, or would it just be too sensitive to the swings?
I think it'd be too sensitive to the swings. I do know that like we do for within the trend tracker, a portal that we allow members to see their actual rate and stuff. We allow them to see like if they're not meeting the denominator, the criteria and stuff. So if they're less than that 30, so they're aware of that.
Okay, thank you.
Kieran, I think I may have had a sound issue, but I didn't hear the answer to your question about planned readmissions. being included or not in the measure?
They're not counted as. They're not counted in the numerator. I think when we said that exclusion, we're focusing mostly on the denominator. So they are not.
Okay.
Millie, I can put it in the chat as well. If you're having audio issue. Yeah, I'll put that in the chat.
Thanks.
So it does, sorry, my coworker is actually correcting me. It does include planned hospitalization.
It does include.
In the prolonged stay. I was thinking about Pro 30, sorry.
Okay.
It does, yeah.
Okay, so now you've got me confused.
Yeah, sorry about that. Yeah.
Okay,
so let me, planned hospitalizations are included in counting in this measure. They are included.
So if you have a planned readmission, it counts as a readmission.
Yes. Yeah.
So Kieran, yeah, is there any sort of facility specific data drill down to where the facility could parse those out? Because I would think that would create some white noise in the metric and an inability to really know what action to take in terms of improvement.
Yeah. So since this is a long stay measure, there's actually very few planned hospitalizations for these long stay residents that's used in this measure.
I mean, it makes me concerned about, the unintended consequences of because they're, the reason that patients are going to these long-term, staying at for a long time is because they've had some very complicated acute care stay. And so if these are patients that are, going to the skilled nursing facility with a trach, with feeding tubes, but now they've improved and they have an opportunity to improve their quality of life by getting back to have procedures that improve their quality of life, it's going to require another long-term stay to get them through that next stage of whatever they're getting back to a normal looks like. So it would be interesting to see what that is, because I know it's pretty significant on the hospital side, and I would imagine it'd be pretty significant on the skilled nursing facility side.
This is a really good question, and I'm so glad it's been raised. I wonder if this does land in the usability, the unintended consequences section. Because this is a big one, actually. And I think Dr. Peace's point is really important.
Well, and Millie's point too, because,
Exactly.
you need to understand what you're going to do to improve the outcome. And if our goal is to improve our patients' quality of life, and a planned readmission improves quality of life, and that needs to be addressed.
I'm sorry, you know what? Thank you. Go ahead, Leanne. Or sorry. It looks like, I apologize. I was corrected. This is validity. So yes, we are continuing the discussion on this. Thank you. May I please call on Janine Savage? Go ahead, Janine.
Thank you. I'm with NetHealth. We have looked with our clients at planned admissions and readmissions. It's one of the things that they were interested to know. When we looked at that across our client base, we saw that planned admissions were extremely rare, even more rare than we had suspected. Some facilities had none. Most facilities in a 12-month period, most facilities had less than 10 planned admissions to the hospital. And with the emergence of most procedures being done as outpatient procedures, we think that probably has had an effect on actual overnight hospitalizations. So, in discussions with our customers, they're very comfortable in having planned admissions counted.
Amy, Sonia has her hand raised.
Yes, go ahead, Sonia.
So I think the challenging thing with readmissions, especially the planned readmissions, is that, it has to be clearly documented, as part of the discharge summary that this patient is going to be readmitted, and then it has to be clearly documented on the patient being readmitted that this was a planned readmission. And, probably, I want to say upwards of 5 to 7% of our acute care hospitals fit into that category, and we're just not properly documented.
Janine, do you have your hand up? Okay. I just wonder if the planned readmissions, which is a sticky point with this group because it's a concern, is it similar throughout, the nation, or the number, like throughout the SNFs, or is there any difference in the SNFs that are doing the planned readmissions with their patients versus the folks who are the SNFs that are not? I'm just wondering if that's been looked at.
I mean, I think as my colleagues are chiming in, like get in the chat and stuff, is that, because this is a long stay measure, you don't really see that many, planned readmissions. Like, there would be a planned hospitalization for this measure, because they have to be in the facility for over 100 days to be included in this measure.
May I call on Lolita Thompson?
I just had a quick question. So I work for an acute inpatient rehabilitation facility, and a lot of times we will send patients to a skilled nursing facility. Maybe they have wounds or some other things that they're medically unstable to, they're not at a point that they can really sufficiently do inpatient rehab for the 3 hours required and at the intensity that's required for inpatient rehabilitation. So we do have planned admissions as far as readmissions. So we'll send the patient out to the SNF. They may stay there a little bit and then they'll come back to us. I was just wondering if the acute inpatient rehabilitation facilities are also counted as the acute care hospitalizations.
So they would need to still be in that nursing home for over 100 days for them to be counted. So it's unlikely for a lot of those types of residents to be counted.
I do want to bring out some chats that we're receiving. So we do have a chat that from David Gifford. This is not a readmission measure, as the denominator is for people who have been a resident in the facility for more than 100 days, and that it's rare for a long stay resident being in a facility for greater than 100 days to go home. So I just wanted to call that out for the record. That's in our chat.
Thank you, Leanne. And regarding the patients in our long-term care facilities who are there for 100 days, regarding the ability for them to avoid hospitalization with the right process and systems, I feel like we can potentially talk more about this validity testing on the accountable entity level, or move on to the risk adjustments. I feel like the risk adjustments need to be talked about. If we can move on. Okay, thank you. Let's go on to the risk adjustment then.
Okay, perfect. I just want to make sure, Lolita, did you have your hand raised still, or? Okay, perfect. Thank you. I just wanted to check before moving on. Thank you. So for the risk adjustment model, I want to highlight that the developer noted that this measure employs 4 logistic regression models applied to 4 discrete subgroups of the denominator population to estimate the risk of any hospitalization during the quarter. The developer noted that while Black and Medicaid status was found to be significant in at least one of the fixed effects models, they found minimal impact on the overall performance of the models as measured by the C statistic. For risk model diagnostics, to assess the overall performance of their risk adjustment model, the developers compare their model coefficients to the mean coefficients from Bootstrap analysis expressed as actual values, standard deviations, and percentages. The developer performed a Hosmer-Liebenschau test for the goodness of fit of the logistic regression model. This test assesses whether or not the observed event rates match expected event rates in subgroups and the model population. So for the risk model discrimination statistics, there were 4 groups. Again, the C statistic ranged from 0.62 to 0.64, and the linear regression model rate of all hospitalizations had an R squared of 0.96. I will hand it back over to the standing committee.
Any comments on the risk adjustment? And is this a time when we talk about whether COVID should be brought in here, or as the developer suggested, to leave it out because its presence is its significance is unclear at this time?
Yes, that's a great question, Amy. So we're evaluating the measure as specified, so that we're going to stick to the specifications and the submissions that were provided by the developer. Great questions though, and discussions that can be had, but we are reviewing the measure as specified.
Okay, thank you. Any comments on the risk adjustments? I just want to make sure Terry Schofield's comment from earlier, has that been addressed appropriately? Terry
Yes,
Shoulder,
it has. Thank you. Appreciate that, Dr. Lynn.
Thank you. Well, let's move on to meaningful differences and missing data.
Okay, so just to confirm, were there any more questions regarding the risk adjustment model, just for the record? I'll do a quick scan, Amy, real quick with a hand raise. Okay, perfect. So for meaningful differences, the distribution of change in adjusted rates was similar across all 4 quarters, where for each quarter, the average change for deciles 2 through 8 were less than plus or minus 3%. Deciles 1 and 10 had average changes greater than plus or minus 3.5%. The distribution of differences was larger for facilities with smaller denominators, and this indicated that recommendations of clinically meaningful differences should be dependent upon facility size. For missing data, I'll go through that and then I'll pause and hand this back over to the standing committee. The developer provided distribution data of the minimum data set 3.0 known outcome rates across the sample, as well as the relationship between the observed rate of hospitalizations and the known outcomes rate. The developer noted that on occasion, a facility may fail to follow the deadline for submitting a minimum data set assessment, resulting in the inclusion of the patient in a quarterly denominator, but unable to provide them with a known outcome following the snapshot date. This is vital to the measure's accuracy. In response, the developer has reviewed the known outcome rates across their samples to ensure that missing data is not a major factor. The developer also selected known outcome rates of 90% to be the minimum threshold for missing data. The median known outcome rate in their full sample of point right facilities was 100%, concluding that missing data was not an issue for the majority of the facilities. And then lastly, additionally, the developer noted a slight positive correlation between the known outcome rate and the observed hospitalization rate, with a Pearson correlation of 0.8 and a Spearman correlation of negative 0.006. Now I will hand it back over to the standing committee.
Thank you so much, Leanne. Any comments, questions, concerns about the meaningful differences and the missing data? I don't see anybody raising their hand. The questions, I guess when we asked the committee ahead of time, do we have any concerns about this? There was no comment on that, and the preliminary rating for validity was moderate. So Now we move on to feasibility.
Just getting my notes up. Okay, feasibility. So this is the extent to which the specifications, including the measure logic, require data that are readily available and could be captured without undue burden and can be implemented for performance measurement. So that's just a high-level overview of the feasibility criterion. The developer noted that all the data elements needed to compute the measure score can be generated and collected by healthcare personnel, during the provision of care, and that all data elements are defined in the electronic clinical data. So this could be clinical registry, nursing home, minimum data sets, and home health. The developer also noted that computation of the measure requires a license to use software for large-scale data management and calculation of risk estimates using the logistic regression models. And lastly, the developer noted that while utilization of the measure specifications does not require a fee, there is a requirement that display, disclosure, or publication of the measure must include the measure's trademark and the measure's specifications that are copyrighted by Point Rate. So we did rate this preliminary analysis as a moderate rating for feasibility, and I am going to scroll through the committee pre-evaluation comments. We had two comments. One comment said data collected can indicate appropriate measures to reduce emissions, and the other comment is that all data elements are already collected electronically. So there was no concerns raised by the standing committee during the pre-evaluation. I will hand it over to you, Amy.
Thank you so much. Let's have any comments or questions about feasibility. I had a question for the developer. For the ProWrite software that requires a license, and it's a really big software program which allows large-scale data management and calculation of risk estimates using the logistic regression model. Is there any concern, I'm just wondering, that since it's one company with one copyright and it's proprietary, then is there any concern that there might not be a drive to improve upon the model, or is there any concern that we're putting all our logistic regression eggs in this one software program, one basket? I mean, thank you.
So I'm not sure if I'm going to exactly answer the question, so feel free to push back and give me some more the question. So some of it with the measure itself, so the rates are publicly available. We put it as in the sense of we publish the rates on our website, so you can download the data and see the rates for all the nursing homes. The trademark stuff is just if you were going to take that download and use it somewhere else, and like you're going to put it on your own website, this is the readmission rates that you label it as Point Right and you put the trademark on it. That's about the licensing, that aspect of it. The using the software and stuff like that, I mean, that is just because the MDS systems, there's so many of them, and just to calculate the logistic regression takes a while and stuff like that. We post our coefficients and stuff like that, so where they're available, like, if another vendor or someone else wanted to run it, we have those coefficients available that people can use to run the logistic regression.
And who pays for it? I'm just questioning, I just don't know. Is it?
Yeah, I mean, we are just absorbing the cost of buying like the MDS assessments from CMS, the ACA and Cal. That's part of our research budget through member dues and other like non-dues revenue and stuff. But there's no specific line item payment that's coming to calculate this measure or anything.
Okay, thank you. Any questions about feasibility from the group? I don't see any hands, so we'll move on to use and usability, criterion 4.
Okay, so I always find it helpful to provide an overview of the use and usability. So I'll start with use as our first criterion. So use evaluates the extent to which audiences, so these would be consumers, purchasers, providers, policymakers, use or could use performance results for both the accountability and performance improvement activities. So we look at accountability and transparency for use. So our performance results use in at least one accountability application within 3 years after initial endorsement, and then are they publicly reported within that 6 years after initial endorsement? If not, then of course we would like to see, if there is a credible plan for the implementation. So when we conducted our preliminary analysis, we noted that the measure developer has indicated that this measure is publicly reported and is currently used in accountability applications and programs, and that the developer noted that this measure is utilized in several state Medicaid programs as part of their value-based purchasing or pay-for-performance programs. For the feedback on the measure of those being measured or others. So there's 3 criteria that demonstrate feedback. 1, are those being measured given the performance results or data, as well as assistance with interpreting the measure results and that data. The second sub-criterion is those being measured and others, other users, have they been given an opportunity to provide feedback on the measure performance or implementation? And the third point is this feedback, is this considered when changes are incorporated in the measure? So those are the 3 criteria that demonstrate feedback for use. So for the feedback on the measure of those being measured or others, the developer publishes the prolonged stay rates on the AHCA's long-term care trend tracker tool quarterly for members to track and benchmark their organization's prolonged stay performance. The developer also publishes facility level rates publicly on their website on a quarterly basis. Results are available in 3 Net Health Point Right solutions: Quality Measures, Scorecard, and New Mexico Value-Based Purchasing. Net Health Solutions offers educational materials on demand. Feedback on those being measured is shared through direct conversations with analytics, product management, sales, and client services team members. And lastly, feedback is also submitted through in-application messaging via email and in conjunction with responses to Net Promoter Scores, customer satisfaction surveys. So the team's preliminary analysis on the use criterion was a pass, and I will hand it back over to Amy and the standing committee.
Thank you so much. Any questions or comments about the use of the measure?
Yes, what does the public data look like? On the public version of the website, is it just a snapshot number? Are there trend charts? What does that look like for those that aren't members and can get into the deeper dive tracker tool?
It's a great question. So the public base, it's more kind of a spreadsheet of just the raw data in terms of just for each facility. We do have a couple of more, I think, public facing that are more friendly to view. In terms of, we have a quality initiative where we included readmissions, and we use this measure as in. So we've had some like issue briefs and stuff where we talk about updates to the quality initiative on a quarterly basis, where we talk about the performance, the number of people that achieve the goal, or reduce, made reductions and stuff.
Thank you for that great question, Millie.
Taking that question and going just a little bit further, I see this as very valuable information for the consumers. And I'm just wondering if any effort or intention is in place to make it so that the data is truly useful and understandable to consumers, particularly those living in SNFs, where they can, where it can be posted.
That's great feedback, and it's actually something I think one of the big takeaways I'm going to actually take away from this conversation is looking and seeing about how we can do that, some more of that. So I think there are some opportunities for that, to do more of that public showing of the measures. I do know one of the things we like about this measure in terms of the public facing is that it's easier to understand in terms of that other measure that we talked about, that claims-based measure, on Care Compare, because ours uses it's a rate, it's a percent, so you get like a readmission rate of 14%. The one on Care Compare, it's a per 1,000 patient days, so you get like a 2.15, and then it's like the difference you get differences on the tenths, and it just, I feel like as a you know, patient or family member, like, what does that mean? You know, 0.2, you know, long-stay hospitalizations, whereas as a percent, I think it makes more sense intuitively. 14% versus 16%, that makes sense. There's 2 less people per 100 people that are getting hospitalized. So I do think we have some more opportunities. We can kind of maybe push this more publicly facing.
Yeah, and also I think when patients are going into long-term care facilities, they're limited usually to a certain somewhat small geographical region because they want to try to be near family or something like that. So it's really the subtle differences make a difference in choosing where people want to be. So I think that this particular rating, along with others, but this particular rating is a very important one that tells a lot.
Great point, and thank you for taking the feedback from this committee, Kieran, and group. If no further comment.
Amy, if so I would like to bring up, we can ask the developer to respond. I know we had mentioned COVID a few times prior, but we can ask the developer to respond on how they plan to address COVID in the future for this measure, if the standing committee wishes for use.
Good point.
So the question is, how we plan to use COVID or account for COVID for use in the future.
Yes.
So we've kept the rates, we keep publishing the rates. We have not blinded any quarter rates during the COVID period. Partly something we've seen CMS do as well on Care Compare with their websites. They paused them for a little bit, but then they actually went ahead and released them. So we have not censored any data that's like during the COVID pandemic to not produce their hospitalization rates. We have just put it out there. And so that's kind of how we continue to keep, so we don't see any adjustments from that forward. I mean, I think mostly we're looking to kind of track it and see how it goes, and then potentially looking forward to doing additional testing later on about whether or not to include COVID in the risk adjustment model.
So if I could just add, from a patient safety standpoint, this is a very sensitive topic because yes, the stress and strain of our different systems and facilities is extremely high at times, you know, during COVID, but that doesn't necessarily mean we shouldn't be using measures like this to indicate where we can do better and what needs to be fixed. Where, you know, when we have problems, we have to learn how to respond to them and not just say, well, it's okay to lose a few more lives because we had a big problem. It's not. And I think everybody pretty much agrees with that. So to factor something like this out, particularly since right now we think that COVID's going to be with us in one way, shape, or form, you know, for a while, I think it's very important to just look at this as kind of a test of our systems. And there may be reasons from payers' points of view why it should impact things, but not in terms of what we're learning about quality. So that's just my say going forward.
Go ahead, Dr. Peace.
I mean, I think COVID is so challenging on so many levels. I think from the risk stratification standpoint, it's incredibly challenging because, you know, it does impact a patient's immune system. So not even the acute care and the acute infection, but, you know, the long COVID and the fact that it's going to, you know, really compromise your immune system. It's going to make your, you know, from a clinical standpoint, if I have a patient who otherwise I probably would have started antibiotics on and kept in my skilled nursing facility versus I know this is post-COVID from 30 days, I'm more likely to take that patient more quickly to the hospital for severe sepsis. So I think it does change your clinical decision making, you know, when you're dealing with patients with acute COVID as well as with long COVID or just the immune impact from post-COVID. But then I think the other level that needs to be looked at is that, you know, clearly COVID impacts different communities in different demographic regions at different times. And it's very hard, to be comparing facilities or peer-to-peer facilities when you have some facilities that will not take COVID patients or even post-COVID patients. And so there's a lot of steerage that happens with patients. And I think most of it's done because you're trying to cohort patients in areas where you can provide the level of care they need. But I think that skews the data in a way that, going back to, something that Lisa said much earlier, is that not every readmission is a bad thing. I mean, there's reasons why patients, may need to be moved out. So I don't know. I think it's a very difficult. It'll be very interesting to see how the data shakes out over time. I think you've got to look at it from the different layers of how COVID is impacting your patient population and your demographics around, who's in that skilled nursing facility.
That's a great point. And I'm hoping that Kieran and his team is grateful for the feedback here about the COVID question, as it's not included as a risk adjustment factor now, which is what we're going to vote on eventually. But for the future, I think our input, I hope, does help you, Kieran.
Yeah, thanks for listening.
No, thanks for sharing.
Well, we've got the usability. If there's no further comment from anybody, I see Dr. Pease's hand is still raised, but I believe that is okay. No problem at all. Then we'll move on to usability.
Okay, wonderful. So for usability, we look at how this measure evaluates the extent to which audiences use or could use performance results. I'm sorry, apologize. My computer froze a little bit on me from my notes. So we're looking at improvement results for this measure. So the developer provided 4 figures demonstrating the improvement of hospitalization rates in the New Mexico nursing facilities. They noted an improvement in average performance from 15.27% in 2020 of the first quarter to 7.81% in quarter 4 of 2021. So there was an improvement between those 2 quarters. They also noted an improvement in median performance from 15.08% in the first quarter of 2020 to 7.01% in the fourth quarter of 2021. They noted that there is no current national value-based or pay-for-performance incentives tied to reducing long-stay hospitalizations, and Medicare's National Skilled Nursing Value-Based Purchasing Program only accounts for short-stay rehospitalizations. Lastly, they also note that there's been no significant improvement to the national prolonged stay rate from 2014 to 2020. In their measure submission, the developer did not identify any unintended consequences with their measure, and they did not identify any potential harms. So I will hand it back over to you, Amy.
Thank you so much. What questions or comments about the usability from the committee? I do have a question about usability and unintended consequences. The vulnerable patients in the long-term care facilities, they live there, they've got high hospitalization rates, as was already mentioned in the beginning of this discussion. And is there any monitoring of mortality in this group? Because if they get sick in their SNF where they live, if they get sick in the long-term care facility where they live, they either go to the hospital and get the care they need, or they might expire if the care they need is not adequate. Any look at that side of that coin, the mortality side?
We haven't done anything related to that specifically about mortality. It's tricky, some of this, I think with some of, it's also respecting resident wishes, they don't want to go back to the hospital and stuff for some of that. I don't know.
Yeah, it's a good point about not wanting to go back to the hospital, but then some people are ready for not going back to the hospital, and then some patients are probably not ready for not going back to the hospital. Oh, we've got Janine. Go ahead, Janine.
Yeah, I think, mortality is an interesting question, and there's so many dimensions to looking at mortality. One of the things that we strive to do with our providers that we work with is to help them identify um, and have the right discussions around end of life wishes and advanced care planning. And so often mortality is not only kind of the expected outcome, but having a better patient experience around their end of life is what they strive for. So it would not necessarily hold true that, if a facility has, a higher mortality rate, that there is really any correlation directly to their hospitalization rate, or a correlation that can be inferred anyway, because there are so many other considerations around the issue of mortality and end of life. Their advanced care planning practices, the way that they interact with their patients and family conferences, and how their medical providers are having those discussions, and the list goes on. And I think this is one of the most challenging areas for providers, and the ones that we work with that are very kind of leading edge are being very very open and honest about identifying end of life indicators and having those discussions. So, mortality is very complicated, and I would just say very much like COVID, needs to be approached very carefully.
Thank you so much. Any other comment or questions about unintended consequences or usability for this measure? I don't believe when the questions for the committee came up, there were no comments on this as far as I know. And the preliminary rating for usability and use was moderate. Okay.
Amy, before we move on to the next measure, I just want to make a correction to the record. Earlier, I believe I may have stated that there was no new validity testing conducted, but there was. I want to make that correction for the record. The developer did indicate that there was new validity testing conducted for the submission since the original endorsement, and that was that correlation between this measure and the prolonged stay and the Medicare claims-based long stay hospitalization measure. So just wanted to correct that there was updated validity testing completed by the developer for the submission.
Thank you very much. May I ask a question then? So for the SurveyMonkey, are we committee members allowed to vote? We haven't, I'm sorry, I haven't yet, which means I just want to clarify, we could go alongside the discussion and vote like at this time, right? Yeah.
That is correct. Yes, and please let us know if you did not receive that SurveyMonkey link, because we can definitely send that out to you.
Well, if there's no further comment, let's move on to, go ahead, Leanne.
I was going to move on to the next measure then, and we can give a second for Victoria to pull up the next measure description for us. Perfect. Thank you, Victoria. So the next measure we'll be reviewing is measure 2375. This is Point Right Pro 30. The measure steward is American Healthcare Association Point Right. This is a maintenance measure. This is an all-cause risk-adjusted rehospitalization measure. It provides the rate at which a patient, regardless of payer status or diagnosis, who enters a skilled nursing facility from an acute hospital and is subsequently rehospitalized during their skilled nursing facility stay within 30 days from their admission to the skilled nursing facility. So I will hand that over then to you, Amy, to lead the discussion.
Thank you so much. As we begin this discussion, this is, the idea being, can SNF rehospitalizations be prevented with systems or processes to help support patients so they don't have to come back to the hospital for avoidable readmissions? That would be ways to keep people out of the hospital from nurse practitioner support in the SNFs, or helping patients get the care they need when they get sick in the SNF after hospitalization. I want to mention the patient advisories are on the phone. That's Dr. Pease and Lisa Freeman. Do you want to frame the discussion from a patient standpoint? And Dr. Pease, I see your hand is up.
I think I forgot to take it down previously. But no, I would like to, I mean, I definitely think this is a very critical measure because, you know, we want to make sure that we're setting our patients up for success in that post-acute space. And as a patient, you want to make sure that if you don't get to go home, that you're going to the best place that's going to get you better the fastest. So, yeah, I think this goes back to a lot of what Lisa was saying earlier, that it's a very meaningful measure because I think that continuity of care and ensuring, you know, good outcome is vital. This is an important way to measure it.
Lisa, any framing comments from a patient advisor standpoint?
Lisa, I believe you're on mute. Okay, we will work with you on the side to try to help you with your audio. Thank you.
Thank you. And so we're very excited to have lead discussant Raj Mahajan help lead us through this discussion of this measure. Do you, oh, wait a minute. I didn't let the developers do their thing. Mr. Kieran Srinivas, can you present this and a 35-minute overview of the measure, please? And thank you so much.
Yeah, I'll keep this short because it's really very similar to the other measure, and so don't want to say the same thing. It's very so this is just, again, this is our short stay version of our measuring rehospitalization. So this is looking at 30 days after admission from a hospital stay, looking at readmissions. It's updated on a quarterly basis, and it represents a 12-month period. Again, like the prolonged stay measure, we have no changes to the risk adjustment model. Mostly in our application, we have updates to performance trends, validity testing, and usability. We've also seen this measure adopted in state value-based purchasing programs, California and Hawaii, for example. We continue to see some validity testing, like strong associations with the Pro30 measure and 5-star ratings and other quality measures such as pressure ulcers, urinary tract infections, things like that. And yeah, so I'll end it there and look forward to the discussion.
All right, thank you so much, Kieran. I'd like to invite our lead discussant, Raj Mahajan, to help move us right into the measure discussion.
Thank you, everyone. Most of the information is included in the slide deck, so not sure if we are putting that up on the screen. So are we just going right into the evidence discussion first?
Yeah, criteria 1, evidence, yes. Importance to measure and report. Thank you.
Okay, so so on the evidence, the evidence requirements for a health outcome measure include providing the empirical data that demonstrate the relationship between the outcome and at least one healthcare structure. So that discussion, so what the developers comments, Kieran, do you want to weigh in on that so we can have our discussion started, or is there anything in particular on the evidence do you want to say from a developer's perspective?
And this is Matt from NQF. Sorry, maybe before we go there, thanks, Raj, for that summary of the evidence. Just make sure that any of the committee members have some questions related to evidence. We'll capture those and then triage to the developer. Thanks, Raj. Go ahead, Amy.
Sure.
Sorry about it.
That's it. Yeah.
And it looks like Sheila has her hand raised.
Yeah, to me, this measure is a bit of a chicken and egg measure, and I'm wondering if someone can speak to the evidence to sort that out, because one could assume that it's a hospital accountability measure, that the patient was inappropriately sent into that setting rather than a long-term care accountability measure.
This is Lisa, and if I'm having trouble hitting the buttons, the bottom of my screen is not accessible, but we've been talking about this in the patient safety community for quite a few years now, particularly with regard to that. And what I think is the consensus that I'm hearing is that it's not necessarily, yes, it is a chicken or the egg, you know, which comes first, but it's really about communication, and it's about handoffs and transitions, and it's about the SNFs knowing what they're looking for before they accept the discharged patient. It's about the hospitals knowing what the patient needs when they get to their next place. And I always understood that is the underlying message that has to be heard by these things, and that CMS is trying to bring attention to it in various ways, as does this particular measure. And I think it's a hard one to get through because everybody likes to kind of say, well, it's their fault. But it's not about a fault. It's about working together so that patients have a proper positive experience.
Yeah, I appreciate that, Sheila and Lisa, because we just had on the acute side, the Medicare spend per beneficiary metric data released, which covers the 3 days prior to acute inpatient, the inpatient stay, and then the 30 days post-discharge. And it's all attributed back to the hospital, right? In hospital value-based purchasing. So I like the idea of having related metrics attributed in the SNFs, because the hospitals are incentivized to work with, the post-acute space. And this type of metric then incentivizes the SNFs to do the same and connect in that work.
This is Raj, and I just wanted to weigh in with the first few comments. It's very interesting. I don't think there has been a lot of discussion about this measure being a measure for acute care to have discharged these patients / residents to a facility prematurely. Since my work is in the field on post-acute, from very beginning, this has been a measure for the facilities and their ability to manage and be able to not have them readmitted. So I think it's a very good point, and I am not sure if there is work being done on somehow using a methodical approach to come to a premature discharge being the issue, and yeah, definitely a great point there.
Thank you so much. I see Ed Davidson has his hand raised.
Yeah, I just wanted to add that I think to echo the other comments, this is a very important measure, and just with regard to the evidence, there's been a couple peer-reviewed papers published in the last 2 to 3 years that that kind of highlight the value of looking at this 30-day readmission, and not a lot of all of this work. That was these two papers that I wanted to highlight was one by Kumar in PLOS Medicine and another in the Journal of the American Geriatric Society by Rivera Hernandez. Look at two important issues. One of what's the impact of Medicare Advantage versus fee for service, and the other is looking at racial disparities. And just I bring them up to a point that they might be useful to add, you know, to the peer-reviewed literature basis that the developer has developed as part of this measure.
Thank you very much. Go ahead. Was someone going to say something?
No, this is Raj. I think since we're discussing evidence here, and per developer, there's no change in evidence since the last time this was reviewed. So I just wonder if the committee has any further discussion on the evidence and the change in it as it stands.
The preliminary rating for evidence is a pass. And so if there's no further discussion, we'll move on into the gap in care opportunity for improvement and disparities.
Ed, did you still have a question or feedback? I see your hand raised. I just want to make sure we don't skip you before moving on. Oh, okay, perfect.
Thank you, Raj. Can you take us into the gap in care opportunities for improvement?
Definitely. So for 1B on performance gap, the developer has provided the statistics for the most recent quarters. And for 2019 and 2020, the risk-adjusted mean rate was 16.6% and 16.3%. The standard deviation was 4.9%. So with a range of 0 to 58.7 in 2019 and 5.2% with the range of 0 to 81.9% in 2020. And then from AHCA member facilities for Q4 in 2011 through Q4 of 2020, the developer noted that rehospitalization rate have steadily declined from 2011 to the Q3 of 2020. The average improvement was 10.4%. And then also it was noted the increase in the national average rate for Q4 2020 could be related to COVID-19 that has been discussed for the other measures as well. So any discussion on performance gap? Any comments? If not, we can go to disparities. And then in disparities, the developer provided disparities data for the entire population of the individuals admitted to skilled nursing facilities following hospitalization, including all races and ethnicities, regardless of payer status. The numbers there, 715 SNFs, and it's 3 million, that 739,243 residents. And then the difference between in average readmission between facilities with low, less than 5%, and high, greater than 35% of minorities has decreased over time. And that is 16.5%. And in 2011 Q4, and 14.9% in the Q4 of 2020. Facilities with fewer minorities have lower risk-adjusted Pro-30 readmission rates. The difference in average readmission rates between facilities with low and high percent of minorities in Q4 of 2020 was 2.8%, compared to 4.1% in Q4 of 2011. Also, the developer provided data by geographical location relative to CDC's Social Vulnerability Index, SVI, and the facilities located in lower SVI counties had lower risk-adjusted Pro-30 readmission rates, and the difference in average readmission rate between facilities in low and high SVI counties has decreased over time, and that that decrease is 2.7% in 2011, and it went down to 1.4% in Q4 of 2020. So, and that is the data provided on disparities. And any comments from the committee on disparities?
So the gap in disparity is narrowing. Has there been any statistical testing on whether or not that's a significant reduction? Do we have any information about that, or just random variation?
This is Kieran from HCA. We have not done any statistical testing yet on that.
Okay.
It'd be interesting to know why the disparity is decreasing. You know, are the hospitals doing a better job in that post-acute space? What interventions are proving successful?
Correct. I agree. So the preliminary rating for opportunity for improvement was moderate. All right. So you can vote silently on the Survey Monkey if you want. And if there's no further comment, we'll move along to criteria 2, scientific acceptability of measure properties. Thank you, Raj.
So on the scientific acceptability, so on that, on the specifications, it requires measure as specified to produce consistent and reliable and credible, which is valid results. And on reliability testing, it demonstrates if measured data elements are repeatable and producing same results with high proportion of time when done again. So on this reliability testing, the developer performed parallel forms reliability testing by calculating several measures based on MDS 3.0. That was submitted by over 2,800 facilities into the MDS 3.0 data, and the developer calculated rates of admission, tracking observed rehospitalization and expected rehospitalization. The developer showed that 206 cases, which is 7%, numbers match exactly both the numbers of admissions and tracking rate. In 1,869 cases, which is 66%, CMS data observed rate calculation minus the SNF data observed calculation rate was 1%. And in 2,652 cases, 2,652 cases, which is 94%, the CMS data expected rate calculation minus the SNF data expected rate calculation was within 1%. The developer noted the results of the testing between CMS MDS 3.0 data and the data from participating skilled nursing facilities was reliable. So any discussion on reliability testing? Do we have any concerns that the measure cannot be consistently implemented based on this? And the preliminary rating for reliability was moderate.
Yes, thank you, Dr. Mahajan. Yes, so I did want to call out that in your survey, Monkey, the question for reliability, the highest rating will be a moderate rating, as the developer did conduct a reliability at the patient or encounter level, so the highest rating would be moderate. So I just wanted to let you know, in case you were wondering that, I wanted to call that out.
So we'll go on validity testing next. And so the developer has compared hospitalization claims submitted to CMS with the MDS 3.0 discharge assessment. And developer noted 82.9% of MDS 3.0 discharge assessments indicating an acute care hospital discharge location could be verified with inpatient claim data. And an additional 3.7% MDS 3.0 discharges could be verified with outpatient claim data. And a total 12.9% of MDS 3.0 discharges could not be verified with the Medicare claims data. Developer noted that validity and reliability of this tool has been confirmed by previous analyses presented in the peer review literature. So any discussion with that data presented? If not, we have validity testing at the accountable entity level. And with that, the developer noted an inverse correlation, which is minus 0.152 with p-value of less than 0.001 between short stay quality measure for pneumococcal vaccination rates at a facility's re-hospitalization rate. Also, an inverse relationship were noted between re-hospitalization rate and the overall 5-star rating, which is minus 0.157 to minus 0.206. Again, the p-value less than 0.001. Also, inverse relationship with health inspection component of 5-star. And I'm assuming that majority of non post-acute folks on the committee and calls are aware of the 3 components of the 5-star rating that compositively makes the overall 5-star rating. And if there are questions, please ask. But health inspection is one of the 3 components of 5-star rating, and which is the health department survey. So for that, it was noted an inverse relationship with minus 0.123 to minus 0.150. Again, p-value of less than 0.001. The second component of nurse staffing, which again is the one of the 3 components of 5-star, and that relationship was minus 110 to minus 174, and p-value of less than 0.001. Facilities that are recipient of ACA's Baldrige based award have significantly lower rehospitalization rate to non-ACA members recipients, and that data is shown there, 17.2 versus 17.7 in quarter 2 of 2013, and that p-value is 0.01. Also, developer compared the measure to 2 other CMS short stay measures, the Medicare fee-for-service claims-based rehospitalization and 5-star. The developer hypothesized that Pro 30 measure performance would correlate positively with the measure number 2510, which is the skilled nursing facility 30-day all-cause readmission measure, SNF-RM, and Medicare claims-based rehospitalization measure, which is NHCRM. The developer found PRO-30 has a statistically significant positive correlation with both Medicare claims-based rehospitalization measures, which is NHCRM. It's 0.622 with p-value of less than 0.0001, and SNF-RM with the value of 0.586 and p-value again less than 0.001. With that, any discussion up until that point on the validity testing at encounter level or validity testing at the accountable entity level? Should we move it along? Then we have some, sorry, go ahead.
No, yes, you may go along. Sorry about that, Raj.
No worries. So we do have some exclusions mentioned here, and then that although there are no exclusion, however, SNFs with fewer than 30 readmission from hospital were excluded during the 12-month period from rehospitalization rate reporting. That's the number there. The developer indicated that average change rates decreased as the number of admissions increased. And that's true. We have a very small facility. It's always hard to interpret that data. One readmission could make like 30% increase in their values. So it's hard to manage that. And then and so also, developer noted while rates for the excluded facilities are not reported, admissions and rehospitalization from these facilities are used to calculate national rate used in the calculation of the adjusted rehospitalization rate. So that is on the exclusions around validity. Then we go along and discuss risk adjustment. Matt, is there, so is this data on risk adjustment and the meaningful differences, is that shared with the larger group?
I can answer that. So yes, we do want to review all of the threats to validity, which do include the meaningful differences in performance and the missing data.
Okay, so we'll go ahead and go over that. So on risk adjustment, so the developer noted that the measure is risk adjusted and uses statistical risk model with 33 risk factors. Developer conducted a bootstrap and stability analysis to test the select patient level risk factors. The developer had a clinical panel review the MDS and identify variables that might be expected on clinical grounds to correlate 30-day readmission risk, and that would unlikely change between the day of hospital discharge and the day of the first MDS assessment. The candidate variables identified include demographics, chronic condition diagnosis, treatments that begin prior to hospital discharge with orders to be continued at the SNF, the functional status items that change slowly, for example, 2% assist. The candidate variables were screened for significant univariate association with dependent variable, which is readmissions to any acute care hospital directly from a SNF with 30-day of admission. Next, a logistic regression formula was then utilized, and then estimate utilizing 39 candidate variables. This was progressively refined into one that utilized 33 independent variables. Of the 33 independent variables, 31 of the variables all had relatively low prevalence in the model building sample, with the exception of ventilator status and suction. And the variables all had relatively low prevalence in the model building sample. The C statistic of the Pro30 model is 0.669 with 95% confidence interval, which is the range of 0.6666 to 0.6851. This means that there is 67% probability that a case, i.e. a person who is readmitted to acute care facility from SNF, has higher predicted risk than a non-case. The p-value of the Hosmer-Lemeshow statistics for Pro30 model at facility level is 0.85. So developer accepted the hypothesis of no discrepancy between observed versus expected proportions, concluding that the logistical model is a good fit. The developer noted that the risk model assumes that an independent variable rarely change between the date of admission and the assessment for the admission MDS. The developer tested this assumption by looking at the change from the first and the second assessment. Number was 203, and 386 assessment that were done 7 days apart. To roughly estimate variable stability, the developer identified 4 variables demonstrating rates of change greater than 10%, which is bowel incontinence, cognition not intact, 2% assist, and oxygen use. The developer concluded that the facility level estimates of expected readmission rates are unlikely to be affected greatly by variable instability between the date of admission and the assessment reference date on the initial MDS assessment. And lastly on that, the developer noted that when the risk model is applied to data collection on the day of admission, it will slightly overestimate the expected risk because patients with values of one for the least stable IVs will be zeros by the day of the first MDS assessment. Then we anything on the risk adjustment before we move on to meaningful differences in the performance? Quite wordy.
I have a question about the C statistic. Is 0.67 adequate for the group? I thought 0.7 was like the cutoff as to it being good enough, but I don't know, comments from Kieran or anybody else? Yes, hi, Nadia, go for it.
Yes, hi. Based on our research with DACA and at PointRight, and as well as on literature that's been published, using claims or MDS data, these are the best statistics that one can find for the rehospitalization models. So 6.76, 0.67 or 6.8 are pretty good, in our opinion, based on literature that's also published by other researchers, and the CMS measures that have already been published as well.
Thank you, Nadia. Thank you, Raj. Any other questions on the risk adjustment?
So next up is meaningful differences in performance. So developer noted that in from Q4 of 2011 to the third quarter 2019, there was an 8% decrease in the national average rehospitalization rate, and it went from 18.2% to 16.7%. And then the developer noted that American Healthcare Association provided data on rehospitalization for all SNFs nationally. For Q4 of 2020, the developer showed that risk-adjusted mean rate performance of 16.3% with a standard deviation of 5.2%. The developer also provided a minimum performance of 0% to max performance of 81.9%. It is unclear if these differences in performance are statistically significant before anybody asks that question. So any comment on meaningful differences? So we do have some missing data, and the developer provided distribution of data MDS 3.0 and discharge records, and the levels of types of missing data by the state. I think that is available as a hyperlink. And the developer noted that the level of completeness is high, defined as 95% of admissions have either a discharge assessment completed by another MDS data indicating that the person is staying in the facility. The developer excluded all facilities with greater than 5% missing data, and when the rehospitalization analysis was done, the developer noted that overall the frequency of missing data is low, and that it is recommended to calculate the degree of missing data in the numerator and not report facilities rate MDS discharge assessment data is missing at least 95% of time. So then we have the comparability. The measure only uses one set of specifications for the measure, and that is the discussion. That is the data on the validity testing, exclusion, risk assessment, meaningful differences in performance, and any missing data. Any comments from committee members?
Dr. Peace, do you want to go for it?
Yeah, I mean, no, I mean, just brings back the same conversation around COVID. Because again, looking at the data and the time periods as collected, especially looking at the meaningful differences, the time period is pre-COVID. So it doesn't change the overall intent of the measure, but I assume if we did it with more current data, it would be significantly different.
Good point. Ed Davidson, please. That might have been, I thought I saw your, go ahead, Ed, thanks.
Yes. Sorry, I wonder if the developer could comment for the committee about the compression of the skilled nursing facility census during COVID, and just observations from ACA at looking at this measure with that regard.
Yes, this is Kieran. So I think we saw some facilities that they no longer had the 30 days, so their rates were kind of suppressed based on the measure itself. So we kept it at 30 for the requirement. Other than that, I mean, we saw the rate go a little bit higher in 2020, the Q4 for that, but overall, I don't think we haven't really teased anything out specifically regarding like the change in census and that impact on the measure. It also is difficult because it varied so much from different areas. We know because the COVID waves just kind of went around in different time periods and stuff. So making sure it's like apples to apples comparison about which is the census decreasing. It's all tough.
So the preliminary rating for validity was moderate. And if there's no other comments or questions for the developer on this validity topic, why don't we move on to feasibility?
So on feasibility, the developer noted that the data elements needed to compute the measure score can be generated for collecting the healthcare personnel during provision of care. All data elements are defined fields for electronic clinical data, for example, clinical registry, the MDS, and OASIS for home health. Developer noted that the computation of the measure requires a license to use software for large scale data management and calculation of risk estimates using logistical regression models. Also, the developer noted that while utilization of the measure specification does not require a fee, there is a requirement that disclosure or publication of measure must include measure's trademark, and that the measure specifications are copyrighted by the vendor point right. So any comments from the committee on feasibility discussion? If not, we can move to the next criteria, number 4 on use and usability. See some heads nodding there. So then
Don't see any hands raised. Yep.
Okay, thank you. So for use and usability, we have use in that first subsection is accountability and transparency. So in there, we have currently, is this publicly reported? Yes. Is current use in an accountability program? Yes. And in planned use and accountability program is not applicable. So on the accountability program details, the measures utilized in 2 state programs. We discussed that before in California and Hawaii as part of their value-based purchasing and or pay for performance programs, as well as individual providers and networks. And then the developer noted that Pro 30 is an all-payer measure and is utilized in negotiating reimbursement rates and incentive payments with Medicare Managed programs and managed care organization with other referral partners. Anything on the accountability and transparency? Any discussion or comments? So then we have subsection 2 of feedback on the measure by those being measures. And so for that, the developer publishes Pro 30 rates on ACA long-term care trend tracker tool quarterly for the members to track and benchmark their organizations for Pro 30 performance. The developer publishes facility level rates publicly to ACA's website on quarterly basis. The Net Health Point Right Pro 30 Re-Hospitalization and QSP performance data are updated on an ongoing daily basis and available to all NetHealth customers who subscribe to the web-based software solution. The developer noted that results of all participating facilities nationwide, is 200 facilities, are presented to Point Right scorecard solution, which updates every month. The developer noted that NetHealth customers share feedback through the following ways: direct conversation with analytics, product management, sales, the client service team members, in application messaging, email, and in conjunction with their Net Promoter Score customer satisfaction surveys. Next, the developer highlighted feedback obtained from NetHealth customer who use Pro30 to monitor and manage their re-hospitalization outcomes. Some of these are users feel secure and in a competitive position as preferred partners for post-acute care. Users achieve and sustain excellence in reducing the re-hospitalization rates. Users feel they can leverage the benefits of communicating with their regarding their re-hospitalizations, and users can prepare for the best position for their organization for value-based incentive and penalties. So that is the feedback from the entities that are being measured by this measure, and overall positive comments. And any discussion on this? I personally think there's so many different ways for them to provide the feedback, and chances of tracking that, because if these are calls to the sales and client success team members, not sure if every single one of those is being logged. Kieran has a smile on his face, not sure if it's related. Any comments? And overall preliminary rating for the use is a pass.
I just want to mention, as I did with the other measures, that again, I think that the use can go beyond the facility and be used by the facility to communicate to the patients and their families, not patients, residents and their families. I think it will just create a positive energy and proper information or helpful information for them to use.
And the feedback from the customers were so positive. I was wondering, and there's another comment in this standing committee, whether or not there was any feedback that helped with possible changes to the measure from the customers.
This is Kieran. I can talk a little bit, I guess, about some of the feedback we've received. Is that kind of the question? Customers. I know one question when I was thinking a little bit about this is one question we've gotten, some feedback we've gotten is looking to potentially look at this measure for like specific conditions, so like your CHF patients or your specific to specific diseases and stuff. We've gone back and forth a little bit about that. Some of it is hard because you have small numbers with that, so it creates some trouble actually getting that minimum sample size to create the measure if you subset it to that. I think there has been some facilities that are large enough that I think Point Right NetHealth has been able to actually create the measure if they have large enough sample size for those specifics, and so I think they've gotten some good use out of that. So I don't know if that kind of touches on getting feedback from customers and kind of adapting to it.
Go ahead, Nadia.
Yeah, just to add to what Kieran said, we do report when appropriate the rates for hospitalization for certain conditions that are relevant to the short stay populations in the facilities. And we do that because the Pro30 model has been very, very stable and robust, not only across time, but also for specific conditions when we subset and we have adequate numbers to report the rates on. So when we are able to do that scientifically, we do it. And this is very helpful to the customers to identify where to focus first, which patients to pay more attention to. And the other way we are also reporting when feasible, it's by day of the week, which again can be very, very helpful to the clinics, because sometimes it's not the conditions themselves that are problematic, but maybe it's staffing issues. So if clinics see, for example, an increase in their rates in specific days of the week, they can gather together and discuss whether staffing changes are appropriate and shifts of their staff members to appropriately care for the patients in their clinics. So whenever we can do it, we report rates in different ways to help the clinics and the nurses and the doctors to identify where they could concentrate more in order to achieve better results faster.
Great, thank you. Thank you, Ron. So no other comments. We'll move on to usability.
All right, so usability has a couple of subtopics. So one is improvement and an improvement in results, and that developer provided rehospitalization rates from ACA's member facilities, and they noted that an improvement in rehospitalization rates of 10.4% from Q4 of 2011 to Q4 of 2020, and that was from 18 to 18.5% to 16 to 16.5%. Also, developer noted that an increase in the national average rate of Q4 2020 could be related to COVID-19 pandemic. And then the other sub topic there is benefit versus harm, and in that the developer did not indicate any unexpected findings associated with implementation of this measure. And no potential harms were noted by developer. Now the questions for the committee is how can the performance of results be used for further goal of high quality, efficient healthcare? I personally, whenever this question comes up with any readmission measure, there is a robust discussion of unintended consequences. So I would open that up to see if, and again, a lot of it is more anecdotal, where facilities do try to keep residents longer to avoid a readmission, and conceptually that could lead to harm or unintended consequence. So, but definitely open it up for rest of the committee to comment.
Thank you so much for bringing that up. Sheila Roman, do you have a comment?
Yes, I would say that I agree with you, Raj. And I think this comes up frequently on this committee, as you've noted, that when readmission measures are created really without the intent of value-based purchasing as their goal, which I think is true for most readmission measures, that the measures themselves have the, have the potential for unintended consequences. And I think where I'm going is that I think under the usability criteria, we really need to be looking at usability for value-based purchasing. And, you know, I think the experience of many that readmission measures have the potential to actually become cost measures when they're used in value-based purchasing settings.
Thank you for that comment. Any comment from the developer on this part of the discussion?
I think these are great points, and I think one thing it's one measure in the sense of I think that's why we sometimes need multiple measures to kind of show the whole perspective, for both residents and families as well as for referral partners and stuff as we're thinking about it. I think one of the things that's been this measure actually isn't used in value-based purchasing programs. The New Mexico example we've provided in there, as well as Hawaii, I believe. So this measure is used in value-based purchasing on the Medicaid, side for the state. Janine, I don't know if you don't mind me letting Janine chime in.
Yeah, I would just say that, unlike the federal value-based purchasing program that uses one claims-based readmission measure, the state VBP programs that are using this measure contain a balance of measures that include clinical and utilization-oriented measures, and a number of measures between 4 and 12 measures typically. So this is not a sole this is not being used as a sole source of evaluation of a VBP state level program, to my knowledge, but is part of a much larger complement of measures.
That's great.
That's very helpful.
It is. Thank you for saying that. I think for the other comment that has been drifting around is the request to the developers, when you do the next evaluation, to please further consider how COVID impacts these measures specifically in the next evaluation as it comes around. So thank you so much. Thank you for this rich discussion. Any other comments on this measure here today? Because if not, we can move into the question of related and competing measures.
So Amy, we, because we're voting offline using our Survey Monkey poll, we will actually need to postpone our related and competing measures discussion to the post-comment meeting. So we will definitely focus on that on our post-comment. But I do have a few more slides, and I know it's approaching almost 4 o'clock on the East Coast. So I definitely want to be mindful of everyone's time. So if we can have Victoria just pull up our last few slides. There's just a few more to-do items on our call. So I'm going to pause a moment. We do want to have time allocated for our NQF members and public to provide comments on this call. So we are going to open up the floor and see if any of the NQF members and public on the call today would like to provide their feedback. So I'm going to pause. Okay, hearing none, we will go on to the next slide, please. Okay, so I'm going to hand over the baton to Tristan Wind, who will go through our next steps and our upcoming timeline. So Tristan.
Thank you, Leanne. Next slide. Perfect. Thank you. Thank you for attending today's measure evaluation meeting. Looking ahead, NQF staff will prepare the draft report consisting of the standing committee's discussion and recommendations. The report will be released for a 30-day public and member comment period in which all comments received will be compiled into a comment brief that will be shared with the standing committee and developers. These comments will also be discussed during the post-comment call. NQF staff will then incorporate the comments and response to comments into a draft report, which will then be reviewed by the CSAC team during the CSAC meeting. Additionally, there will be an option for an appeals period to provide the public an opportunity to appeal the endorsement decision. Next slide, please. So due to achieving today's meeting objectives, the measure evaluation follow-up meeting will not be taking place. Therefore, you will receive a cancellation notice for the meeting on June 29th from 1 to 4 p.m. following the conclusion of today's meeting. Additionally, the draft report comment period will occur from August 3rd to September 1st. Additionally, the dates for the post-comment web meeting, CSAC review, and appeals period have not yet been finalized. So once those do become finalized, we will communicate those dates accordingly. Next slide, please. And then here's the project contact information, our email, readmissions@qualityforum.org, our phone number, project page, and committee SharePoint site. If you are to have any questions or concerns, please reach out to us here. And we'll turn it back over to Leanne for outstanding questions and closing remarks.
Wonderful. Thank you, Tristan. So yes, I will pause here to see if anyone on the standing committee has any questions about today's call or following the measure evaluation meeting today, to include the voting that will occur offline with the SurveyMonkey link. Well, hearing none, if you do have any questions, once we adjourn the call today, please feel free to reach out to our project team. Again, we're here to assist you, provide you support. We will send out that SurveyMonkey link to the committee members that were not in attendance today, along with a copy of the official transcript, so they will be able to review those materials and place their vote. We will also provide the due date of that vote once we send out that email communication. So I do appreciate you bearing with our new process today on the call. And I'd also like to go ahead and provide my thank you remarks to everyone today. I really do appreciate your patience and your engagement and participation. I definitely want to thank our co-chair, Amy, for leading us through the spring 2022 measure review. Thank you to our lead and supporting discussants for your facilitation and preparation leading up to our meeting. A big thank you to our patient advisors who are on the call to provide that valuable patient perspective to the work we do. We greatly appreciate those words and that feedback that were provided all throughout the call. So very, very big thank you. And additionally, I'd like to thank our developer team for your time and effort leading up to the meeting and attending today to present and address any questions that the standing committee had during the conversation. So we definitely greatly appreciate your participation and your attendance today. And then I'd like to also thank my team who has worked so hard to put all this together for you. Isaac, Tristan, Victoria, Tarun, and Matt, thank you for your hard work and dedication to our project. We'll take down our slide, and I would hand over the baton to Amy to provide her closing remarks.
Thank you so much for the rich comments, the great questions. I appreciate all your input here today, and I appreciate everybody who unmuted and contributed to the conversation so much. Special hats off. Thank you to the discussants, Millie West, Ed Davidson, Dr. Pease, Lisa Freeman, Raj Mahajan, and then to the NQF staff who helped this whole call go so smoothly. So thank you so much to Leanne and team and the developers who brought this to our discussion today. Have a great weekend. This is about it for this meeting, I do believe. Thank you for all your help today.
Wonderful. Thank you.
Thank you.
Yes.
Thank you.
Have a wonderful
Thank you.
Thanks. Bye-bye.